Hi, and thank you for tuning in to the Charles E. Holman Morgellons Disease Foundation's YouTube channel. I'm your host, Jeremy Murphy, and today we have a special guest joining us, Morgellons disease expert, Dr. Ginger Savely, author of Morgellons, The Legitimization of a Disease.
Yes.
Hey, Dr. Savely, how are you doing this afternoon?
I'm good. How are you? Thank you for inviting me on. It's always fun to talk to you.
Yeah, these are always great conversations. Well, for those who don't know, could you tell us a little bit about who you are and how you're affiliated with the Charles E. Holman Morgellons Disease Foundation?
How I got into all of this stuff.
Well,
I was working for a long time as a family nurse practitioner, and those are people who do primary care. And so I used to do basic care needs of people, things like physicals and colds and sprained ankles and those kind of things. But members of my family and myself as well started getting Lyme disease. And so I became very interested in it, started learning as much as I could about it, going to conferences, reading about it, because, with a personal connection. And so once I learned about it, I began picking it up in my population of primary care patients. People would come in with a new onset of headaches, and then I would think, well, let's look into the possibility of Lyme disease. So before you knew it, my practice kept increasing in the amount of Lyme patients I had, and then before I knew it, that was all I was doing. Wow. I was treating only Lyme and co-infection patients. And then I guess it was around 18 years ago, I started to notice this subset of my patients who would have lesions and would have long fibers coming out of the lesions. And I could see these myself, and sometimes I would try to extract them, but they were very difficult to extract and would cause pain for the patient. And I started looking more carefully and seeing very many unusual things that at first really surprised me, and it was hard for me to believe what was going on. I showed my colleagues. Most of them didn't believe me either. They thought the people were mentally unstable and that this wasn't a real disease. But I knew what I was seeing, and so I decided I wanted to try to help these people, but I didn't really know what was causing it. And all I knew was there was some kind of a connection with Lyme disease because it was popping up in a subset of my Lyme disease patients. And when I say Lyme disease, in a way, that's kind of a shortcut for just saying tick-borne diseases. I don't just literally mean Lyme disease. I mean Lyme and other tick-borne co-infections. And so because these people all tended to have tick-borne infections, because I would check all the Morgellons patients that came to me, and almost all of them did test positive for at least one tick-borne disease, well, I just began to treat them for those and found that most people did start to get better. Some had an easier time getting better than others. Some people had the symptoms of Morgellons for so many years that it was very difficult to get them well. Others had it maybe only 6 months or a year, and I found those people were a lot easier to get better. But I just kept working away through the years on trying different things, because not everybody responded to the tick-borne disease treatments. Some people, we just had to experiment, and I would try different things, everything I could think of. I would try giving them antiparasitics, antihelminthics, antifungals, antivirals, you name it, because we didn't really know what we were dealing with, so we just try different things and see what happened. And my patients realized that this was all experimental, but they were more than happy to try things to see if they could feel better. And then over the years, certain treatments began to be clearly more helpful than others. And so before I knew it, people started coming to me than just for Morgellons disease. And I began to attract a lot of people just with that, because there were so few people who would help them or even believe them. Yeah. And so now I'm in a position where I believe, haven't figured it out, but I would say probably about 80% of my patients are Morgellons patients right now.
So when you talk about Lyme disease, you're talking about like a complex of pathogens.
Usually so. It's pretty hard for a person to have only Lyme disease. When you think about, first of all, even ticks carry so many pathogens, at least 30 known pathogens. So the chances of getting strictly Lyme disease are pretty slim. Plus, people often have many other viruses and other immune burdens that we have to deal with in order to get them well.
Wow. And was it the case that many Lyme physicians weren't willing to accept a potential association with Morgellons early on?
Well, I found the Lyme doctors were a little bit more open-minded than other doctors were. The other doctors who were not used to, well, let's say thinking outside the box, were very critical of me and assumed that I was really just playing into people's delusions. There was a lot of anger at first. And when I first started doing this, a lot of doctors would call me and yell at me and tell me that I wasn't doing these people any favors, that they needed to be in psychiatric hospitals, and that it did not do them any favor to encourage their delusion, which is what I was doing.
Sure.
Or sometimes they even suggested that I myself was delusional because of the fact that I was seeing these things in people. And I would just say, well, come on over to my office and let me show you some really interesting things, because you're not going to believe what you see. But it's interesting, they never wanted to take a look.
Yeah, because the evidence is rather compelling.
Seeing is believing, and this is definitely the case here.
Dr. Savely, the CDC recently reported 115,000 new cases of syphilis in the United States. Some people may assume, and is it the case that Morgellons is really syphilis?
I actually have not heard that, but routinely through the years, whenever I've checked someone for Lyme, I've always checked a syphilis test too. It's one of the few things that could cause a false positive on a Lyme test. So we always like to have a syphilis test just to be able to show, okay, we don't have a positive Lyme test because of the patient had syphilis. But I don't think there's any reason at all to think that what's going on with Morgellons patients is related to syphilis. It's really a very different thing entirely. I mean, the distinguishing characteristic of the Morgellons patients is having these filaments and other debris, let's call it, coming out of their skin. Sometimes it's little seed-like objects, little black specks, sometimes even bigger shards of collagen, just different things coming out of the skin. And that's something very unique and very, very descriptive of this disease, is having these various exudates from the skin.
So the ulcerations are, they may look similar, but there's different things going on with them.
Yeah, exactly, because the diagnostic feature of Morgellons disease is these filaments. Is you can compare Morgellons disease to many other skin conditions, and in many ways it can be related. It can be very close to many other skin conditions, but the distinguishing feature that always sets it apart is these unusual filaments, which now the research has shown are made of the body's own proteins. The filaments are inanimate objects, and they are made of proteins, collagen, keratin, the kind of proteins that the body produces. Why the body is producing these in different places and larger quantities than usual, that remains to be seen. But maybe something is going on where DNA in the cells is getting altered to the point where cells are doing the wrong place at the wrong time. And that's kind of a basic assumption to go on here, at least when I go on anyway.
Well, there is some recent research which demonstrates that Lyme bacteria does have an effect on skin cells in particular that invades. And as such, and in your work, you've been able to demonstrate that antibiotic intervention is able to heal the condition.
Right.
Some patients, however, are afraid of utilizing antibiotics because of either the resulting side effects or the concern that there may be long-term damage. Are those side effects limited to fluoroquinolones, and are there ways to mitigate these potential reactions?
I don't use a lot of the fluoroquinolones because people are so worried about tendon damage and tendon rupture with those. There are some vitamins people can take to help, but I just find that because there's so much worry about it, I don't want patients to have to be concerned about that. And so I don't use the fluoroquinolones anymore. And, there is some concern too with medications like metronidazole and tinidazole causing long-term neuropathies that can be very severe.
Oh.
But the way around that is we pulse those so that people are not taking them continuously for a long time. And I found that with pulsing them, I don't see that that problem. The only other antibiotic that I can think of that we use that could potentially have a problem, and this is a 1 in a million kind of thing, is with Plaquenil. And Plaquenil has been known to cause retinal detachment. It's a very, very rare thing. Before using it, we always have a basic eye exam and an eye exam every 6 months after that. I don't use a lot of Plaquenil anyway with my Morgellons patients, but it is something that I always warn them of if we're going to use that. All in all, I've really had a pretty successful time treating people with long-term high-dose antibiotics. I'm always saying this is a desperate times call for desperate measures kind of a situation. I don't love the idea of putting people on high-dose antibiotics, but if it's the only thing that works, people are more than happy to put up with a few side effects that they may have, such as some nausea at the beginning, maybe loose stools, which we can get around by giving enough probiotics. Just some of the discomforts of taking the antibiotics are far outweighed by the fact that people do start to feel so much better and their symptoms start improving. So, cost-benefit ratio is always the thing, right?
So, well, there are some legitimate concerns, but there's also a game plan to mitigate those potential effects.
Right. And we're always looking at the lab work to make sure there's no harm being done to the liver, kidneys, just monitoring that constantly. And everyone's taking probiotics to protect their gut, and they're taking various liver protective herbs for their liver. And I've seen that, people really do very well. And I've had people on many high-dose antibiotics for years getting rid of this thing. And that's the least of my concerns, really, that the antibiotics themselves are causing people problems. I'm much more worried about the disease and what that's doing. And I always give the example to my patients. It's kind of like being on chemo for cancer. Chemo is highly destructive. It's the worst thing you could do to a person, put them on chemo. But, if it helps them get over their cancer, then it's worth it. And that's kind of what we're doing here. We've got people that are desperately ill, and we've got to find some way to get them better. And it's not the ideal. Like I said, I don't enjoy putting people on a lot of antibiotics, but if that's what's helping them to get better, then it's worth it. And every patient is more than happy to do it.
Well, and Morgellons isn't the only condition that people heal with long-term antibiotics. Isn't it true that severe acne, rosacea, cystic fibrosis patients, don't they have to take long-term, maybe even lifetime antibiotics?
Yes, that's true. A standard treatment for tuberculosis is 2 years of 2 antibiotics. And so, this is not an unheard of thing to give long-term antibiotics. I've even known diabetics with bad foot ulcers who are put on antibiotics for a year. So, it's not an unheard of thing. It just, I think the reason that so many doctors get upset about it being done with these patients in particular, the Morgellons patients, is they're not convinced that what they have is a physiological problem, is an infection.
Right.
And therefore they feel like it's kind of crazy throwing all these antibiotics at somebody who, from their point of view, probably has a mental illness. But it's very, very clear, these people don't have a mental illness. I mean, I have been treating Morgellons patients for 18 years, treated about 1,000 of them, examined them. I can see all of the things that they talk about. I see them get better with the antibiotics. And so there's no doubt about it. There's no doubt about what's going on. Just some people don't want to know and don't want to look. They don't take the time to look.
There's also outdated procedures that aren't considerate of the science, which has demonstrated that this very old bacteria has some new tricks that we just didn't know about. And well, let me ask you though, we are dealing with a bacterial infection that can cause damage to a person's system, all their systems basically. And that's going to cause or result in a lot of debilitating conditions. Medical marijuana is becoming more readily available throughout the United States. Can Morgellons patients utilize this tool to address some of their particular symptoms? Are you finding that your patients have found success with using medical marijuana?
Oh, they certainly have. It's helped with so many symptoms. It's helped with, of course, most of my patients have extreme difficulty with sleep. And so it can help with sleep. It can help with the pain that people have. And also nausea is a problem. Not only some of my patients have that as a symptom even before they start the antibiotics, but the antibiotics can create a lot of queasiness, particularly at the beginning before somebody gets used to them. So I find it to be very, very helpful. And, you know, I'm always right behind people using it if they can get their hands on it. I mean, I know we can get a lot of different CBD oil and full spectrum cannabis oil even through the mail, and I believe everybody in the country can get that now. And so the biggest problem I find is that it's expensive. You know, the good stuff is expensive, and it's not like you can get it with your health insurance or anything like that. So sometimes people will tell me, oh, I tried it, it was fantastic, worked really well, but I just can't afford to use that on a regular basis.
Wow. Well, now the treatments themselves, though, even the antibiotics are becoming comparatively expensive. Is that right?
Yeah, and hopefully, I mean, most people actually can get them covered by their health insurance, and so they're paying a copay, you know, like whatever they have with their insurance. Some people 10, 15, 20, just depending on what their arrangement is with their health insurance. But for the people who do have to pay cash for one reason or another, like say they have a insurance with a very high deductible, well, then we're always encouraging those people to use the GoodRx app on their phone and find out who has the least expensive prices for these various antibiotics. Now, most antibiotics we're using are generic now, luckily, but there are a few that are not. And some of them are extremely expensive. But, you know, we just work with that. Sometimes I hate to say that we have to make choices in treatment based on cost, but it's the reality. And that's so true that sometimes I don't get to do the ideal treatment on a patient because they can't afford it and their insurance won't pay for it.
So poverty really is a factor in a patient's prognosis.
Yeah, and when you think about it, so many patients with Morgellons, they've gotten so sick, they've often lost their jobs and therefore lost their health insurance. Many of them have lost their families. Their families won't stand by them.
Yeah, that's right.
They have deserted them. They've lost their friends. They're in really bad state because they don't have anyone to help them financially or in any other way with what what's going on with them, which makes the whole situation all the more desperate and very, very sad. And there's just many more people out there with this disease than the few of us who are treating it can take care of.
Wow. Well, let's change gears for just a second here. On your website, you recently updated with a statement that says that your patients must cease cigarette smoking before engaging in treatment. Can you explain why patients will not improve unless they quit? And what about other forms of tobacco like vaping or dipping?
Well, what I kept seeing is that my patients who smoked just cigarettes did not, they either didn't get better, they didn't get as well as I thought they could. It really stood in our way. You know, smoking tobacco is an immune suppressant, and it's particularly difficult for anything in the skin to heal because it does tend to make the blood flow very poorly through the very finest capillaries. And therefore, any kind of a skin condition is going to be very hard to heal when a person is using tobacco. And so since it used to be the first thing I would ask a patient would be to give up smoking, so now I just say, okay, just do it before you even meet me and get that out of the way, because I feel like we're working at cross purposes if they're continuing to do something that is so bad for their immune system while we're trying to get them better, you know? So it doesn't make sense.
No. Medical tobacco is not the same thing as medical marijuana, basically.
Medical tobacco? I don't know. So. I don't know about that.
Thank you for clarifying that for us.
Sure.
One common symptom that patients present with are artifacts that present under their skin, oftentimes inside ulcerations. And these have been described as white worms, seeds, shrimp, cocoons. But researchers have described them as collagen projections, follicular casts. How do we know these aren't worms?
Well, I think, that's pretty easy to determine in the laboratory. And when they analyze these things that come out of people's skin, they can clearly see what they're made of. And then, first of all, they can very clearly see that they're not organisms. They're not worms. I mean, that's pretty easy to determine in a laboratory, right? And so the idea all along with this has first been to determine what these exudates, what these things that come out of the skin are made up of. And when we determine that they're not living organisms, but that they're proteins, that pretty much negates the idea that these can be worms or insects or different things that sometimes people believe they are. They often do look very much like worms or insects. I can tell you that. I've seen that myself. But I think your eyes can deceive you sometimes. And, what's much more important is what they're finding in the laboratory when they take these things apart and analyze them. And when they do that, they can very quickly determine that they're not worms or insects.
Yeah, I sent some specimens into a parasite testing lab one time, and they did tell me the report back that it was connective tissue, in fact.
Mm-hmm.
And so no worms, no seeds, no cocoons. These are just
they look like seeds, I know, but they're not actually seeds. But I think, what we have to be careful of is what we call these things, because if we call them seeds rather than saying something that looks like a seed, then that's when often other doctors who are not believers in this will get really frustrated with people and say, well, that's crazy. You don't have seeds coming out of your skin. And you actually don't have seeds coming out of your skin, but what else are you going to call them? Because they look like that, right? And so it's just kind of shooting yourself in the foot if you're a patient when you use some of this terminology that then predisposes healthcare providers to think that you're a little bit crazy. And so I think I've always encouraged patients to really describe what's coming out of them rather than giving names to it. So saying things like, little black specks or little white colored round things, or long filaments, or fleshy blobs of fleshy looking pink stuff, or those kinds of things, just sort of descriptive rather than giving names to what they're seeing.
So the tactic is to avoid determination and rely on description so that the doctor can make that determination.
Exactly, because I have to say, and it really shouldn't be this way, but I tell my patients this all the time. It's all about you don't want other healthcare providers to immediately get prejudiced. You want them to take you seriously. And there's certain things that you can say that immediately prejudice them. Now, in a way, you could say, well, this is kind of playing games, but honestly, you just need to do what you need to do in order to get people to listen to you. And so I usually have, there's sort of a way we tutor patients, and I know the nurses do in the Morgellons Foundation too, as far as what language to use when you're talking to other doctors, because that can make a big difference in how seriously you're taken.
Yeah, and you're not being deceptive at all. If anything, you're admitting that you don't know, but that you're not relying on your initial judgment. Maybe other evidence, which will prove to be factual, may change or evolve your understanding of what's occurring.
Exactly. You got it.
Well,
that's exactly right.
But we still have a problem with these things because appearing under the skin, appearing inside ulcerations, they feel like needles. They feel oftentimes like splinters, like you just fell on a cactus. What is the responsible way to address these things besides leaving them alone if a doctor doesn't know what to do with them? What can a patient do to address these things without digging them out with, a pair of fingernail clippers?
I think sometimes these things do have to be taken out because when they're causing a lot of pain as they penetrate through the skin. When you think about nails, your fingernails are made out of keratin. And if you had a little thin piece of nail working its way through your flesh, it's going to be very painful. It's like somebody sticking a big pin through your flesh. So naturally it's painful, and naturally people feel a desire to want to get in there and dig out the thing that's causing them so much pain. It makes perfect sense. It's not a sign of somebody being crazy. It's a sign of somebody being adaptive, somebody trying to deal with the situation at hand. Unfortunately, people end up having to do it on their own because they can't get a doctor to believe them that there's something in there. And then, of course, you have to run into the problem of maybe infection because they're not doing it in a very clean way. I think mostly, though, people do have to get these things out of there. And we've always just assumed in terms of clinically, when it comes to treating people, that it's a good idea for these things to come out. Like whenever I first start treating people with antibiotics, they always say, wow, I have so many more fibers and filaments and black specks and all those things just came pouring out of me when I started the antibiotics. And I've always assumed that's kind of a good thing. That's what we want, to get it all out of there because it's causing a lot of pain and discomfort for the people. So, nobody knows for sure, because nobody knows exactly what's going on with this thing. So we just pretty much have a clinical view from years of doing this. I've just noticed that when we can give somebody something that helps them get rid of these things that are tormenting them, then that's a good thing. That helps them feel better.
So really, the first, like a couple months of antibiotics, but then the symptoms start going away for most patients?
Yeah, it's so variable. It depends on the age of the person, how long they've had it, what other immune challenges they may have. There are just so many factors that make each patient so different and how they respond to treatment.
Yeah.
But kind of sort of typically, or let's just say on the average, people will feel way worse in the beginning in terms of having more biting, crawling sensations under the skin and more things coming out of their skin. And sometimes that initial stage is so hard to deal with. People just say, I can't do this. I don't think I can continue with treatment. It's just too hard. But if they can hang in there, for 2 or 3 weeks of the worsening part, then they get over the hump, and then they really start to feel better. But it's rough. And sometimes for certain people, it's rougher than others. And in those cases, we do have to maybe slow down the treatment and to a point where they can tolerate it.
Well, it's not just feeling better, but they have less ulcerations and less of these
Right.
collagen balloons filling up their folliculars.
Yeah, the first thing I always hear is they stop having new lesions. The lesions they have begin to heal up, and then they begin to have less filaments and things coming out of their skin. But honestly, the thing that usually gets better first are what I call the physiologic symptoms. In other words, most of my patients just feel pretty rotten, like they're sick. They feel achy all over, and joint pain, and extreme fatigue and weakness and headaches and foggy brain and all these different symptoms. And those symptoms tend to get better before the actual Morgellons symptoms do. In other words, I call them Morgellons symptoms, the ones of the lesions, the exudates, and then the biting and crawling sensations. And often those do take a little longer to get better than the systemic symptoms do.
So patients, they're going to develop, Morgellons patients are going to develop sores regardless if they're trying to excise whatever they feel underneath the skin or not, because the skin ulcerates. The infection causes ulcerations.
I don't see too much of that. Not all of my patients have lesions. So I'd say, kind of a rough guesstimate here, about 15% do not have lesions at all.
Wow.
And they have the filaments, they have the sensations, but they don't get the lesions. And some of those people think, well, I guess I don't have Morgellons, but that's not right. I mean, some people are lucky and they don't get the lesions. Some people are covered head to toe with them. So I think, there's many different variations in how people get this. Some of my patients have it as a annoyance, all the way to people who are completely disabled with it. And so I see a wide spectrum of how it affects people. And I would assume that would be the same reason any illness would affect people differently, just based on their individual immune status. Their age always has a factor here. And some people just are more receptive to the treatments. They seem to respond better to treatment. And I'm not even sure exactly why that is, but we never know until we just dive in and start doing it. People always want me to tell them right up front, like, okay, what's going to happen? Exactly what's going to happen. And I'm not able to do that until I can see how they respond, because it's just so variable. I've never seen anything be so variable as this. For the most part, when you treat a lot of other diseases, you're going to see a pretty similar course in the way people respond. and how it proceeds. But wow, this is just all over the place. Every person is so individual. A treatment that works fabulously for the first patient, the next patient won't work for at all. So it makes it very difficult. And this is why I can clearly see why many healthcare providers don't really want to touch this disease, because you really have to, each new patient is a whole new ballgame, and you've got to really figure everything out based on that patient. It's you can't follow an algorithm, you can't follow a cookbook for this at all. It's just all over the place.
Yeah, it's kind of hard to develop a standard of care. And also there's a multitude of potential pathogens involved.
That's right. And the thing I emphasize the most to my patients, and in my treatment manual I wrote for my patients, is, we all have different immune burdens on our systems. And there's just only so many burdens our immune systems can take at once until they finally just crash. Like that's it. I can't take any more.
Yeah.
And everyone has different ones. I mean, which include even psychological ones. Some patients have PTSD, or they're living in a abusive relationship, or they're living in an extremely toxic house in terms of mold, that kind of thing. There's so many different things that in people's lives and their environment that can affect their immune system, that all of this also has an impact on how well they're going to respond to treatment and whether they're going to be able to get better.
Yeah, we were talking the other day about previous treatments even impacting a patient's ability.
Yeah. Exactly. I have found that if people have been treated, but they've been undertreated, in other words, the dosages have been too low, or they weren't treated long enough, when that happens, that's when you get the bacterial resistance, because when you undertreat, you kill the weaker bacteria and let the strong survive. The way I treat, really hard and strong and long, that it's like there's no bacteria that can survive that. So people always are so worried that you're going to get bacterial resistance from treating people with high dose long-term antibiotics. The way you get bacterial resistance is the opposite, from treating people with antibiotics when they don't really need them, like for a cold, or people taking their antibiotics for 2 days and saying, oh, I feel better now, and then they don't take the rest of them, or people being undertreated with too low a dose. And I see that happen a lot too. And so those are the kind of situations that allow the stronger bacteria to survive, make the super races. So, but I've been doing this now for, like I say, treating the Morgellons patients for 18 years this way. And I've never, ever had a unfortunate kind of outcome or anything like that. The worst case scenario is that the person doesn't get a lot better. And those are usually the people who've had it for a very, very, very long time.
Yeah.
And it's just so entrenched that it's kind of hard to get at. But honestly, I think pretty much I can say this for sure, that all of the treatments all the people get better. It's the amount of better that's different. The worst cases may only get a little bit better, but what we always hope for is getting the person as good a condition as we can. And many times people will only get 80 to 90% better, but it's such a significant difference in their lives that they're happy with it. They can go on and they can do the things they used to do, and it doesn't really get in their way.
Getting to the point of being functional, basically.
Right. And also I think there's a certain something about taking the worry away, because before you ever see anyone and this thing starts happening to you, which is pretty creepy and awful, you're pretty freaked out about it. What is this? And when you go to somebody who basically reassures you and say, yeah, this is a thing you definitely have, and other people have it too, and we're trying to figure it out.
Yeah.
It takes a lot of that worry away, and the worry gets in the way too of getting well.
Yeah, but then that's a devastating experience when the opposite occurs, and you go in and then you're accused of doing it to yourself, and then your family won't help you because they think you're doing it to yourself. And
yeah, there's so many sad stories of things, people just losing their families, losing all their Oh my gosh, the stories are very, very sad of what happened to people with this.
Why do some Morgellons patients shave their heads?
Well, I think that for the most part, well, first of all, a lot of my Morgellons patients do lose a lot of hair. And I've had actually maybe a handful of them go completely bald. Women go completely bald.
No.
But a lot of them lose patches of hair. And so they kind of want to just shave it to just get it all off of there. So that's one reason they do it. But also, there's so many lesions and irritations in the scalp that they kind of want to just shave their head so they can be able to apply things that are soothing to the area, because you can apply things to the rest of your skin, but it's kind of hard to on your scalp with all the hair there.
Yeah.
So when they shave, they're able to then, apply some things that might make them not feel so bad, that might decrease the pain or help the healing, that kind of thing.
Yeah, so it's not really a dramatic thing that people are making it out. They're just really trying to make it easier to help themselves.
Absolutely. That's what it's always about with all this whole thing. Everything anybody does is always just an attempt to try to deal with this bad lot that they've been given. These people aren't crazy. They've just been given a very, very difficult thing to deal with, and they're doing the best they can. And it's not only painful and very life altering, but it's really upsetting too, because the most upsetting thing is having everyone in your life and all your loved ones turn against you and not believe you. And that's a pretty heavy thing.
That's some serious emotional trauma.
It is, and this is why we do see a pretty high rate of suicide in Morgellons patients. I'm very sad to say that I have had 10 of them commit suicide, and just 4 last year, and I can understand why it happens. I mean, when you do feel just so hopeless, and you feel like everyone's turned against you, and you're miserable, and you don't see any reason to live. But I do want to tell people that may be out there and have this disease that we are working on it, that there are researchers trying to figure this out, even though we do need more money for that. There are people like me that are trying to help people. Even if you can't come to me, I'm always very willing to help other doctors treat their patients with this. So what happens is, many times people will ask their doctor to just shoot me an email, and I'm happy to. I reply to them within 24 hours and give them a lot of information about how to treat this. And so don't give up hope, because you're not the only one out there. There's a lot of people have this, I think, far more than we have any idea. And there is hope, and we're going to get this thing figured out, and you can get better. So really reach out for help if you're feeling at that point where you just don't think you want to keep trying. Don't give up.
As a Morgellons patient, it may be beneficial to reach out to, say, your local Lyme disease organization.
That would be your best bet, because generally speaking, the Lyme doctors are going to be a little more open-minded about this. Their conferences always include some information on this. And so that's going to be your best bet over just going to your family doctor. Although I'm continuing to be very pleased and surprised to see that more and more doctors are picking up on this. I have patients coming to me now where they say, oh, my family practitioner told me that I have Morgellons, but they said they just don't know how to treat it, so they sent me to you. That's a big change, because in the past it was always they were just told they were crazy, rather than saying, oh, well, you have something I don't know how to treat. That's a big step.
So yeah, well, having someone on your team, or at least who has your best interest at heart, isn't as impossible to accomplish. With many people who have the resources available to at least get a general practitioner or a family doctor, because then they can contact you. They
Right.
can go through ILADEF training to become knowledgeable with the most up-to-date information that we have. Of course,
Right.
that's hard to accomplish when,
Yeah.
getting funding, to accomplish it. But
Yeah.
in regards to the information and the facts about Morgellons, though, my bad. Um,
Real Morgellons dilemma.
what It's hard to recommend people get involved with the Morgellons group online because of the misinformation. You
Yes.
could tell someone to, go to a Morgellons group on Facebook, and then they end up a couple of days telling you about how the chemtrails are, throwing
Mm.
nanobots. And so that's
Yeah.
why I think it may be better to see the Lyme organization. But is this misinformation and sensationalizing Morgellons with, aliens and all that, is that really harmless? Is it just kind of like a fun thing that people do, or is it something
Mm.
that we should be concerned about?
Well, I don't think they do it for fun. I think they really believe it. And like I discuss all of those things in my book, and, kind of basically one by one, all those different theories and why they are not or cannot be correct. And, so I think that is a very harmful thing, actually, when people propose these outlandish theories, because it doesn't help us advance the seriousness of this disease with the scientific community, which is what we're trying to do. We're trying to be taken seriously and understood by the scientific community that this is something that really needs to be looked into, and research money needs to be given to. And so when a lot of time is wasted on kind of crazy conspiracy type theories, it continually sets us back in the scientific world. And so it's really not helping us at all.
That scientific connection is actually what will help our relationship with our families and communities ultimately.
Sure, exactly. Exactly. I've had many people say that just giving their family my book it just totally changed their lives, because I wrote the book in a very simple way, not a scientific way. It's just for the general population, and kind of help their family understand that, wait a minute, this is a serious thing. People are really looking into this. People are trying to treat this. This isn't some crazy thing I just thought of myself. I mean, this is real.
Yeah, that's the thing, is that it's not just you and a few people, constrained here in the United States. There are actual scientific organizations in other countries that are accomplishing Morgellons research, which adds to the legitimacy.
Right, exactly. So we just need a lot more money for research. We're not getting it from the big places. Something like Zika virus comes along and they throw millions and millions at it, and we can't get any money. And we're just, the little research that we've done, it's a really tiny bit over the years, is just based on just some little personal donations, and also because the researchers have donated their own valuable time and resources to do this. But when you're researching the cause of a disease, we're talking a lot of money that's needed, and we're just not we have not been able to do that yet. About 10 years ago, when some of us had applied to the NIH for funding, and the response was, we do not give money to diseases that don't exist. So, how are you going to prove it exists if you can't get the money to do the research, right?
Oh, man.
Yeah.
Well, okay. If supposing that someone out there watches our interview and feels compelled to want to donate to the cause, what can they do?
Well, the best way is through the Charles E. Holman Foundation, and You can look that up. I don't know if at the end of these things you give website addresses or email addresses or anything like that, but the Charles E. Holman Foundation is the place where I give money and where I would have any other person donate money to, because we are at the Charles Holman Foundation, we're helping the few researchers we have do what they can. So we've had some fairly nice sized donations, but they're always they're relatively small when you think about all the money that's needed to research a disease. So anybody listening to this who happens to be in a family that has some money to donate, this would be a good place to do it. Charles Holman Foundation.
Yeah, and they're listed with the we're listed with the Guide Star, and so it's legit. What's next for Dr. Ginger Savely?
Just keep on doing this. I tried to semi-retire a few years ago, and I moved down here to Mexico, where you're talking to me right now. Wow. And started cutting way back on my patients, just because, I'm 69, so I'm at that age where I thought that's what I should do. But I found that I miss it too much, and it's too much an important part of my life and what I do, and it's a passion of mine. So I'm actually trying to move back to the United States now, to Washington, D.C., where I was practicing before, and just take on more patients again. I've never stopped. I've always had patients. I just had cut way back, but I just kind of can't stay away from it, I guess. So
we definitely need your expertise in this area.
Can't understand why more healthcare practitioners aren't just absolutely fascinated. I mean, can't understand it.
Well, like you said earlier, that misinformation with the chemtrails and the aliens, I think, really stops people from wanting to consider the potential for science.
Lyme, as in Lyme disease, Lyme DC, as in District of Columbia, @gmail.com. So LYMEDC@gmail.com.
We're going to include that in the description below, as well as a link to your website. I'll put a link in the description below on Amazon where they can put Morgellons, the legitimation of a disease. Dr. Savely, this was a great interview.
Thank you. Thanks, Jeremy. It's always fun to talk to you.
Always. Take care, my friend.
Okay, you too. Bye-bye.